I'm speaking for something that is important and different. That is the combined treatment of the spine lesion surgery and the radiosurgery. You know that I begin with a very important expression of Henry Marsh. Henry Marsh is a big friend of Albanian department, that he told the most difficult of my job is not to make surgery. The most complicated to decide to make it or not, and to live with the consequence. And this is a very important concept, because from this concept, we have to decide which kind of surgery we have to do. I begin to demonstrate your case. There is a young girl, 48 years old, with breast cancer, diagnosis in 2011. When she came to my consulting room with MRI, you can see here there is a big lesion in the D8, in the thoracic part of the spine. And there is another case. There is a patient. There is a patient of Dr. Petrella. I think that there is a patient with 61 years old with a lesion in the junction, bulbomedular junction, with very progressive tetraparesia. There is another case that we can resolve this case later, but in the beginning, I want to demonstrate you this case to understand why I take the decision that I took. This is another young girl with 38 years old woman. She came to my consult with a very severe tetraparesia. She was going to one hospital, another hospital. They was thinking that there is something of the myelopathy, cervical myelopathy, and something discal cervical hernia, but was not so clear. Well, if we're speaking about the spinal lesion, we can see that the most frequently there are metastases, later are neurinoma, therefore meningioma, and ependymomas. Now, every year in the United States, we have 118,000 new cases with spine metastases, and from them, 20,000 are spine lesion with medular compression. And it is very important statistically that many of these lesions are intramedullary. There is very important pathology. Well, we think that the most frequent cancer of that produce metastases in the spine are the cancer of breast, therefore the cancer of lung, and the cancer of prostate that is normally in the men's. And the type of the cancer are renal, thyroid carcinoma, sarcoma, lymphoma, and melanoma. In pediatric age, we have normally sarcoma and medulloblastoma. The most important pathology of the metastases are the medullary compression. The majority of the cancer, the medullary compression, is in the dorsal spine. The localization of the metastases, therefore, are in the lumbar spine, and therefore are in the cervical spine. As I told you, they are very important, that are localized in the intramedullary. There is a very big, very important pathology. We have to change the concept. We are speaking how the metastases are going to the spine. It means that it's a different concept from the brain. In the spine, there is a complexity. There are some other elements that are called osteoclast and osteoblast, and they make possible the implantation of the metastasis in the bone. You know that the philosophy of the implantation of the metastasis in the brain is that through the vascular way. But in this case, there are more different elements that make possible the implantation of these metastases in the bone. Well, we are speaking about the treatment. We have different options. There are medical, surgery, radiotherapy, combined treatment, and radiosurgery. Those are our options. How can we resolve the problem of the patient? But to take this decision is not because we decide to make some kind of decision. No, it's based on very determined criteria. The first one are SINS criteria. The second is Bliski classification, TOMITA classification, and NOMS criteria. It means that everything in medicine has to be based in some very clear concept. Well, if we're speaking about Siemens classification, we're speaking about the motility of the stability of the spine. If the spine is not stable, we have to make surgery to fix the spine. And those are the criteria. We have stable in the classification of from 0 to 6, are potential unstable from 7 to 12, and are unstable from 30 to 8 points. In the third group, is sure that we can make surgery. The first option of treatment is surgery. Later we can discuss in the second group if to make surgery or if to make combined treatment. But in the third group, every people have to go to the surgery. TOMITA classification also very important to introduce us in the concept of the treatment, because he's speaking about that how is the distribution of the tumor and which part of the bone is occupied from the tumor. Well, we're speaking about the NOMS criteria. NOMS criteria are very important because we are speaking about the metastasis, that the metastases of the spine are not a separate pathology. We are speaking about a systemic pathology, because if we have a metastasis in the spine, we have to think that we have a primary tumor, and we can treat this pathology thinking that it's a systemic disease with a local localization, and which is the metastasis. For this reason, the NOMS criteria are very important, because are neurological, oncology, mechanical stability, that's included Siemens criteria, and systemic disease. If we're clear, we can classify it as NOMS classification, NOMS criteria, we can make radiotherapy, systemic treatment, and surgery. Well, in 2005 in Lancet, Patcher published this big paper, and was a very important phase 3 paper about the value of surgery. It means that he demonstrated that the surgery was more efficacious than the radiotherapy. And you can see here in the result of Patchell that the people that make surgery, the people in the surgery group, the survival is 126 days. And the people that did not make surgery was only 100, the survival, the medium of the survivors, 100 days. This made that every people was thinking about the surgery. But in 2005, when Patcher published this paper, very important in Lancet, we have not the new technology to make radiosurgery in the spine. And you can see here that we changed the idea of the treatment. Well, you ask more and less what NOMS criteria, speaking about medullary compression, myelopathy, radiculopathy, histology of the tumor is very important, hormonal and chemotherapy response, radiosensitivity, mechanical instability, and systemic disease. Those are what Mark Bliski demonstrated are important to make the decision of the treatment. But the question is that every patient can be operated. Did we have complication in the surgery of this patient? Of course we have. And we have to think more, we have to have an open mind when we decide to treat this kind of a patient. Is the surgery the first option? Well, until now, the most important problem was the spinal cord radiation toxicity. This was a big obstacle in the treatment, because in the radiotherapy of the spine, I'm not speaking about radiosurgery, for this is made the difference. In the radiotherapy of the spine was very important, the toxicity that produced in radiation of the spine. What's happening with spinal radiosurgery? We transfer all our experience in the brain radiosurgery, and we are going forward to make something different, that is a spine radiosurgery, in the same way that we treat the patient radiosurgery of the brain. We have the development of the technology that permits us to make radiosurgery. You can see here We begin from cobalt therapy, we are going to LINAC, we are going to gamma knife, we are going to proton therapy. And now we have something, a new machine that is TAP. You have this a very important machine that is the best in the market to make radiosurgery. Well, when we introduce this concept of radiosurgery, we change the paradigms. This is very important because in the last 10 years, we are not speaking about surgery. We are speaking about the combined treatment, surgery, radiotherapy, and this is the NORMS framework. You understand which is the framework? How can we treat the patient? This is the flow of the treatment of the patient. And for the first time, we are speaking not only about the stabilization, but we are speaking about the radiosurgery and the new concept. We can see later the separation surgery. We can see later what is the separation surgery. There is another phase 3 study published in 2017 in the Lancet Oncology that introducing every year, we are introducing a new concept. The surgery is not the best option. We can see we can make different treatment for different patients and different situations. Which are the indications for spinal surgery? We can make in the radical tumor after surgery, recurrent tumor, multiple lesion, unfavorable localization, and high risk for open surgery. There are many patients that cannot be operated for different reasons, because there is some cardiac pathology, there is some diabetic pathologies, means that they cannot be operated. In this situation, we have to think about something else. The radiosurgery of the spine is some kind different from the radiosurgery of the brain, because we have different indication, different technology, different clinical result, different dose limitation, which is very important, and different organs at risk. Well, when I decided to make radiosurgery of the spine, I am very carefully because of the toxicity. I base all my criteria in standard university criteria of treatment of the spine to preserve the functionality of the medulla. Well, there is evidence support. It's not so much because it's a new concept of treatment. If we're speaking about the surgery of acoustic neuronoma that Professor Okahara told us before, there's a big experience, but we're speaking about the spine. We have 10 years of experience. 10 years experience in medicine is a short time of experience, but we have something that we're speaking about, a new concept, combine surgery and radiosurgery. Does it work? That is strategy work. I will demonstrate you that is very interesting strategy of treatment of this patient. We have some paper about the treatment of spine metastasis. We told that is the first pathology, and in this paper we demonstrate that the combined treatment, surgery and radiosurgery, is very important. And this is the last study, and very new one that we call Canadian schema. That is phase 2, phase 3 studies, very important. If we have phase 2 and phase 3 studies, mean that this establish the policy of the treatment. With this study, we can decide how to do because we have support. This is very important because the phase 2 and phase 3 study make us to be sure in what we are doing. Well, this is combined treatment, surgery and radiosurgery. You can see here that the other concept is the separation surgery, which is a separation surgery. What does it mean, this concept? We can, I'll explain you that the concept of the separation surgery is to separate the tumor from the medulla, from the spine medulla, to take out the compression, and to make radiosurgery after. Well, until now, many people, for example, Dr. Lafuente is a big specialist in the spine tumors. He made a corporectomy maybe sometimes before. But now we can see that if we make corporectomy, if we take out all the bone and we make and we put the element of support, is not enough, because we have to irradiate. We have to irradiate in the same place, because we have a tumoral cell there. For this reason, maybe we change this concept. We are going out from this concept, because we use in radiosurgery two very important concepts that are abscopal effect. That is very interesting effect, that we can irradiate one part and we have a result in the other part. Yes, it is true, Dr. Lee. And bystander effect. There is another very important effect that is the effect of radiotherapy. Which are the bystander and abscopal effect? Are immunologic effect. It's very important, because we have to hear more and more about the immunological effect of the radiotherapy. What does it mean this? That we can irradiate the metastasis in the lung, maybe the other metastases that are in the spine can be disappear. This is the immunologic effect of the radiotherapy and the immunologic effect of the radiosurgery. This is the first publication about the radiosurgery of spine. My friend Marshevich do it about 287 lesions. We collaborate a lot with Marshevich. It's a big neurosurgeon and radiotherapist. He have both specialization, neurosurgery and radiotherapy. I have my own cell. I have 52 patients treated with a combined treatment, and with a big follow-up, 42-month follow-up, and with separation surgery in 38 patients. The majority of the patients you can see here are malignant tumor, and the legs are benign tumor. And the localization are in vertebra, intramedular and extramedular and intramedular tumor. I treated 7 patients with intramedular tumor that are very, very, very important. This is our very interesting case. We gained the third place of the best international publication in the world about this intramedular metastasis. This patient, I treated this patient with 5 brain metastases. Later, she came to me with this intramedullary metastasis. We discussed to make surgery, but the patient was intact in a neurological point of view, and I decided to make radiosurgery. It was my first patient that I make intramedullary radiosurgery, and we decided to make single dose. It was very important. We do 40 grade single dose in May 2012. You can see the MRI in October 2012. It disappeared, just disappeared. We can see here in May 2031, year later, there is no tumor. You can see on December, we think that there was a tumor. That was the reference of a tumor, but it was not true. The patient was quite intact in neurological point of view. And the last MRI, 2 years and a half after the radiosurgery, we have a cyst there without neurological deficit. And the patient died 3 years, but without from the dispersion of the pathology in the body, not from the brain metastasis, not from the intramedullary metastasis. She called me, I think that 2 or 3 days before she died, she called me to the hospital and she told me, you know, you can see I'm not dying from the brain metastasis and from the intramedullary metastasis. I'm dying from the lung dispersion of the tumor. When we published this case, and this case was the 3rd international premium for the best publication in this year. This is another case with intramedullary metastasis. You can see here, we decide to make radiosurgery. With very good result on the patient, and the tumor disappear. Now I come back to our case. There was 3 cases that I explained to you. This is the first case. You can see here the big tumor, the big compression of the tumor, and I decided to make the separation surgery. I make surgery, I take out all the tumor because the spine was unstable, but related with the SINS criteria. You can see here, I make a posterior arthro base in T-square shape. You can see that the medulla is clear. There is no tumor there. This is the surgery, and this is the MRI after surgery. You can see there is no tumor. Everything is free. To stop here, no, I have to treat the metastasis. When I decided to make radiosurgery, you can see here the radiosurgery of the patient, and she was, all the time that she lived, was without neurological deficit. Now, the case that Dr. Pezzella operated, he made a biopsy, was very, very interesting case because nobody was a PET scan, nobody was thinking about it is. And he made biopsy, and the biopsy was a melanoma. And we spoke together, and Dr. Pezzella decided to bring it to me and to make radiosurgery. Was a very good decision. I make radiosurgery. This is the major surgery. And the patient actually, I have not the MRI, but I've seen Monday the MRI, and the tumor is half, was 40 millimeter, and now is 7 millimeter on the patient. Improve all the movement on the right side. It was a pulse. It was very interesting, and we decided to make radiosurgery with a good result. This is the other case that I make surgery in this case. It means that I make a posterior approach to this big meningioma. Was very big meningioma. You can see that the medulla was almost disappeared. I make surgery. This is the MRI after the surgery. You can see here, I am taking out all the tumor. I remove the medulla in the cervical. Was very difficult surgery, with a big control of the breathing, and because we are in Jackson, C1 and C2 was very difficult surgery. I make a posterior approach. I take out all the tumor, and you can see now this is the tumor. The medulla is in this position. On this one was medulla. This is everything was tumor. I take out. There is the rest of the tumor. The problem is that what to do in this case, to make immediately radiosurgery or to wait. I think that because we are speaking about the meningioma, I decided to wait to see what's happened, because the patient improved the neurological situation. But 1 year later, you can see here that the tumor became bigger. And in this situation, I decided to make radiosurgery because the tumor became bigger. You can see here the radiosurgery, and the patient was stable in neurological point of view. This is another case of neuroenoma, which is D1 neuroenoma. We make an open surgery. We make a transthoracal surgery with a thoracic surgeon. We take out the bigger part of the tumor, but it was impossible to take out all the tumor, and we decided to make radiosurgery later. This is another very interesting case. It's an intramedullary ependymoma. The patient was tetraplegic, was very important tetraplegic, where she came to my hospital. I decided to make surgery because I was not clear which kind of diagnosis was. You can see here, I take out all the tumor. You can see here with the posterior linea media approach, I take out all the tumor, and you can see the MRI here, there is no tumor. The question was the ependymoma, grade 2 ependymoma. I did not decide to make surgery because in the grade 2 ependymoma, it's not necessary to make radiosurgery immediately. We have to wait, and if we have a tumor growth, we can make radiosurgery. This is a different case of ependymoma that I make surgery. I take out all the tumor, but in 1 year, there was a recurrence. You can see here, and I decide to make radiosurgery. And 1 year follow-up after the radiosurgery, you can see that the tumor had disappeared. It means that I show these two kinds of meningioma to demonstrate that not everything has to make radiosurgery. No, we have to have a criteria to do it. We can make surgery if we can take out all the tumor. If a ependymoma grade 1, we resolve the problem of the patient. After, if the tumor becomes to grow up, or we have recurrency, we have to make radiosurgery. The big problem of the radiosurgery of the medulla is radio-induced injury. It means that this is a big problem because the medulla is very sensitive of irradiation. But if we are clear what to do, we have a clear of criteria, and with the appropriate technology is very important. It's very important the technology. We cannot treat it good or well a spine tumor with all the machines that are in the market. We have to have very specialized market technology to do it. And I think that the best, in my point of view, the CyberKnife, and later you can see in the part of the neck and head, the sub, but the CyberKnife is a selected machine to make radiosurgery of the spine tumor. Well, I come back to the result of my patient, where the 90% in 3-year follow-up control of malignant tumor, we have 100% control of the tumor in 5 years, and we have no grade 3 toxicity in 100% of the patient. Maybe the neurosurgeon don't understand it, but we're speaking of grade 3 toxicity is that if you were to use medication to control the toxicity. And the conclusion are the strategy of combining with less aggressive surgical decompression roll-up to make radiosurgery later. I think that we have to think about the combined treatment of spine lesion, and we have to treat about the concept of separation surgery. Are very important, new concept we have to apply every day in our hospital. And we are speaking about intramedullary hematitis, in my opinion. Maybe there are my colleagues who not agree with me. The best option is the radiosurgery because it's safe and with very good result. I have more or less 20 patients with metastasis. 7 of them are intramedullary, and the result